Single contrast barium enema. Rad 440, image presentation and evaluation, a presentation by Allure Moore. Two images, AP axial and lateral. So the barium enema is to look at the large intestines. So large intestines aid in digestion. They do that by absorbing water and electrolytes, turning it into waste. The single contrast barium looks for bowel obstructions and severe inflammatory bowel disease. For today, we are going to learn the instructions given to the patient prior to the exam, how to prepare the room and the patient, history questions, technique, IR size and field of view, views, anatomy, markers, and visibility of detail. Before the exam, we want our patient to know how to prepare for before the exam 24 hours. So the large colon must be emptied for this exam. So a light liquid meal the night before and only clear liquids ingested after midnight. We want to give them a bowel cleansing regimen. So we are going to use two different types of laxatives. One, we are going to use the magnesium citrate at 8 p.m. and the tablets at 10 p.m. For the room, we want to set it up so we prepare the table bucky and put blue pads on the table. Remove all clothing and radiopaque items and have the patient change into a gown. We want to fill out the pregnancy screening tool if needed. The supplies for the BE. We want to get an enema tip, enema bag, reusable squeeze inflator, KY gel, hemostat, gloves, towels, and blue pads ready. Some history questions that we can ask the patient beforehand. Are you experiencing any nausea or vomiting? Any abdominal pain? If so, where? Blood in the stool? If so, what color? Is it black and tarry? Or is it red? We could also ask them about unexplained weight loss / gain, any constipation and or diarrhea, general weakness or tiredness, any abdominal surgeries, either on gallbladder, appendix, hysterectomy, any scopes, colonoscopy, any previous UGI / barium enemas, and any allergies. Next, we're going to look at the technique, IR size, and field of view. We want to use a 14 by 17 lengthwise or crosswise board, 40-inch SID for both, large focal spot, 120 kbp for both views, 8 by 15 mass for the AP axial, and 20 to 40 mass for the lateral, center cell, and a 12 by 1 grid. If we're using the blessing floor room, that SID will increase to 45 inches, and the grid will increase to, I think, 15 by 1. Just a little of anatomy before we go into the pictures. We are just going to want to focus on the SI joints, the pubic symphysis, obturator foramina. We have our hip, which is synovial, diathyroidal, freely movable, ball and socket. We want to know just a little extra anatomy review. We have the ilium that makes up 2/5 of the acetabulum, the ischium that makes up 2/5 of the acetabulum, and the pubic that makes up that last 1/5. We have our iliac crest, our ala of the ilium, our ASIS, which will be our centering kind of landmark. We have our ischial spine, ischial pubic rami, inferior pubic rami. We have our ischial tuberosities, pubic symphysis, as I said before. For these pictures, the AP axial, we're going to start with. We want our patient supine. The CR angulation, either 30 to 40, typically we use 35, cephalic, entering mid-sagittal and 2 inches below the ASIS. So if I get my little paper out and I measure right down the middle, I would say that it is pretty well at the ASIS and pretty well in the middle. Structures demonstrated are the rectosigmoid area centered to the IR, the rectosigmoid area with less superposition than in the AP projection because of the angulation of the CR. The transverse colon and the flexures do not need to be included. So a little bit of anatomy of the large colon. We do have our cecum that has the appendix attached to it that goes up to the ascending colon, the hepatic flexure, the transverse colon, the splenic flexure, down to the descending colon, to the sigmoid, and the sigmoid colon, down to the rectum, the rectocanal, anus, and then anal sphincter. For the lateral, we want our patient in a true lateral position, so perfectly on their sides. Typically, we have their arms like in a frame, so they can get their arms out of the way. We want their shoulders on top of each other. And for the CR, we want it enter mid-coronal and level of ASIS. So for these pictures, we actually do not really need the superior portion of the colon. We just want to really see that sigmoid, rectosigmoid area. So you cannot see it because my face is in the way, but we're kind of cutting off the balloon, if I'm being really picky, just a little bit. So if we could just go up with the patient or down with the board and the tube, I feel like we'd be able to see that a lot better. The structures demonstrated are the lateral of the rectum, the distal sigmoid area of the colon. This will be the best image to demonstrate the rectosigmoid free from superposition. And like I said before, the superior portion of the colon does not need to be included, but the entire balloon does. So that's why I said we should go up with the patient a little bit because the balloon's a little bit cut off. For our markers, we want to use a personal technologist marker on both images and for our visibility detail, we will see a short scale contrast with adequate penetration of barium. If we do go back, we do see that we have pretty good adequate penetration, and we can also look for rotation through the ala if they're symmetrical, the SI joints, and the obturator foramina. Some pathologies that can be found on a single contrast barium enema. Like I said before, bowel obstructions and inflammatory bowel disease, tumors, polyps, and Crohn's disease. Here are my references.